Hello, everyone, and welcome to this free webinar presented by WePassed. My name is Christina Ruiz, and I will be your moderator today. Throughout the webinar, we will stop the presentation to review. There will be multiple choice review questions which you will be able to answer in the polls section. Please go ahead and respond to these questions as they come up. You will have less than a minute to answer each one. During the webinar, please feel free to use the chat to ask questions and discuss the topic. We will take time after the presentation to answer these. This and other recorded webinars will be available to WePassed subscribers. You can register through wepassed.com to become a subscriber. Today's topic is MRI in Radiation Oncology, presented by Dr. Jeffrey Clark, Professor of Radiology at the University of Texas Health Science Center in San Antonio. Thanks for joining us, Jeff.
Glad to be here. Welcome, everybody. Good evening. Today we're going to talk about the pending applications of magnetic resonance imaging and radiation oncology. If you attended the previous webinar, you'll recall that we went over some of the basic concepts of MRI, including the nuclear magnetic resonance phenomenon, the description of the transverse and longitudinal relaxation times, or T1 and T2, the basic components of an MRI system, and the general way that the NMR signal is spatially encoded to localize where the signal is coming from to produce an image. Today, we want to talk a little bit about MR image quality and expand on the first webinar, but we also want to get into some of the applications of MRI in radiation therapy treatment planning in particular. So we'll be talking about some of the basic pulse sequences and how they control image contrast. We'll touch on the MRI artifacts that are important in radiation, that are the most important ones in radiation therapy, and the type of MRI scan parameters that are generally required for radiation therapy studies. And then we'll go into some of the issues that you have to deal with when using MRI data for treatment planning, including distortion corrections, CT simulation, and we'll finish up with a few examples of RT-specific imaging protocols so you can get a sense of the kind of issues you have to deal with on a case-by-case basis. So the benefits of MRI are several. Probably the most obvious is the superior soft tissue contrast that you can get. And not only that, but MRI's ability to be tuned for different types of contrast. So you can delineate multiple factors with soft tissue. This enables us to obtain both anatomic and functional information from MRI data. And probably, to me, I think the most important, but still not fully developed, is the potential for quantifying biomarkers of disease stage and response to treatment over the course of therapy. So this is just an example of the differences in contrast between CT and MRI. On the left is a CT image, and on the right's an MRI of the same brain. And you can barely visualize the tumor in the CT image on the left, but it's very clear in the one on the right. And so this is what we mean when we're talking about better soft tissue contrast. Another thing that's enabled the application of MRI to radiation therapy is a number of technological developments that have occurred in the last decade. We moved to 3 Tesla systems that provide greater signal to noise and much more flexibility in the type of imaging sequence you do. And in recent years, 3T systems have been available with 70 centimeter bore MR scanners. So you can put large patients in them. You can put other equipment like patient positioning devices in them. It's not that tight a fit. They've also developed motion correction techniques. We'll talk a little about those later. And these systems have now come with flexible high channel count RF coils that allow a great deal of flexibility of which part of the body you image and how you image it. And as we'll see, one of the important considerations when doing MRIs that you'd like to do everything you can to image them in the same position in the MRI scanner as they will be when they receive their treatment in the accelerator. There's also been a number of new systems developed. We won't really talk about them in this lecture, but they include intraoperative MRI, PET MRI, and hybrid therapy MRI systems where Linacs are incorporated with MRI systems. So to review a little bit of the basic MRI, the basic images are generally characterized by one of three types of contrast: T1 weighted, T2 weighted, or proton density weighted. T1 weighted are considered the best type of contrast for just gross structural information or anatomy, whereas T2 weighted images give information on biological characteristics and tend to highlight pathologies. However, neither of these approaches provides a sensitive or specific diagnosis of localization in prostate or breast cancer or anything else. And so radiologists use multiple different contrasts in order to diagnose particular types of contrast, and they have a good understanding of the way contrast varies in different types of pathologies, including different types of cancers. Also, the tissue properties that give rise to the differences in the relaxation times are not closely related to the tissue structures that define the cancer. So, though you can often visualize the cancer very well, you may or may not get deep information about the state of the tumor, whether it's malignant or not, for example. Now, the basic pulse sequences used to produce these types of contrast are probably the first and most robust is called the spin echo sequence. It uses a 90-degree radio frequency pulse to excite the spins and then a 180-degree pulse to refocus the spins. And the signal that comes out is called a spin echo. And it's acquired at a time that's twice the time from the 90-degree pulse to the 180-degree pulse. And you have your slice select and your phase encoding and your readout going on as well. And you can adjust this sequence so that you highlight T1 or T2 contrast. By adjusting the parameters called the TR and the TE. And so by adjusting the TR, you adjust how much T1 weighting the sequence has. The shorter the TR, the more T1 weighting you have. By adjusting the TE, you adjust the T2 weighting, and the longer the TE, the more T2 weighting you have. And so T1 discriminates certain tissues from each other. The tissue type with the shortest T1 is fat, and it recovers very quickly, and you'll get a bright image even on short T1 scans, where the tissue with the longest T1 is water or cerebral spinal fluid, and then all the other tissues are somewhere in between. T2 is similarly, the signal, however, in water goes away slower, so because it has a long T2, whereas fat, it goes away much more rapidly. And by combining these two properties, you can really adjust a lot of the different contrasts, but there's really a lot more you can do with MRI. For example, here's a T1 weighted image of a couple of legs. And if you look very carefully, you might be able to find this lesion here, but you wouldn't be all that clear about it. But if we were to get rid of all the fat and you give a T1 weighted and fat suppressed image, you can certainly see there's a lot more signal coming from this leg, and you see where the lesion is here compared to the normal leg. So this is one way we can increase the contrast, and this particular approach uses what we call inversion pulses, or it's a inversion recovery type sequence that causes this type of contrast to stand out. But the standard spin echo pulse sequences are not particularly fast. And it takes anywhere from 5 to 10 minutes to acquire a set of images. Faster MRI pulse sequences have been developed. One of these that provides T2 weighted contrast is called the turbo spin echo, or sometimes it's called the fast spin echo sequence. And it increases the speed of imaging by acquiring multiple spin echoes and encoding different lines of data with each echo. And actually increases the TR a little bit, but it reduces the number of TRs signal you have to acquire. So overall, that will reduce the scan time from anywhere from about a factor of 4 to 32, depending on the particular type of study. So you can get your T2 weighted scan down from an order of 10 minutes down to order 2 or 3 minutes. For T1 weighted scans, the pulse sequence used is called a gradient echo, or sometimes a gradient refocused echo. Rather than reducing the number of TRs, they just reduce the TR very short. Remember, the short TR is more T1 weighted, and they reduce the flip angle in order to preserve the amount of magnetization that's available for the next pulse, acquire the next signal. And this is enabled, again, by going to higher field strengths where you have plenty of signal to work with. And so both types of sequences are used for three-dimensional scans. That is where you're acquiring data from a whole volume instead of a single slice. And that is what's generally preferred in radiation therapy to produce what we call high-resolution isotropic images. Isotropic means the voxel is the same size in all three directions, or close to the same size. So with the turbo spin echo sequence, we got one 90-degree pulse and then 180-degree pulse, and we acquire signal, as with the spin echo sequence. But this goes to one line of data, image data, and phase encoding. But then we do another 180-degree pulse and acquire another line, another 180-degree pulse. Like I said, typically it's on the order of 4 to 16 times the scan speed, but in some applications you can even acquire a whole image in this manner in just one echo train. Gradient refocused echo reduces TR. It's less than 10 milliseconds, often less than 5 milliseconds. TE is less than 5 milliseconds, often on the order of 2 or 3 milliseconds. And so you're acquiring lines of K-space every few milliseconds, and you can fill up a slice of a scan in a matter of seconds, 10 seconds or less. So you're really increasing the imaging speed with these two approaches to imaging. And you can accelerate things even faster. With newer MRI technology employing what's called parallel imaging, you can replace some of the phase encoding steps using an array or matrix of multiple RF coils. And that, again, depending on how it's configured, can increase the scan time from a factor of 2, which is quite common, up to a factor of 16, which you find on your most high-end 3 Tesla scanners. There are also what are called single-shot techniques like echoplanar imaging that apply all the gradient steps and acquire all the data in a single signal reception and can get a whole image in less than 100 milliseconds. However, those have poor image resolution and they're susceptible to major geometric distortions. And echoplanar imaging is most commonly used in radiation therapy studies that employ diffusion-weighted imaging, which we're not going to go into detail on in this lecture. There are some newer methods called sparse sampling methods. A couple of the key examples are those of compressed sensing and MR fingerprinting that offer even greater increases in imaging speed by being quite selective about which data points are actually acquired and doing that in a very strategic manner. And this opens up the ability not only to acquire more data more quickly, but also to acquire data with different contrasts all at the same time in a single acquisition multi-parametric study. But again, that's beyond the scope of this talk. So anyway, I want to see if you understand some of these basic concepts we just talked about. Which of the following intrinsic parameters has the greatest influence on soft tissue contrast in standard MR images? Is it electron density, water concentration, quantum levels, or relaxation times? Hello?
All right, so let's go ahead and get that poll up. All right, so here it is. Everyone, if you could go ahead and answer this question, and we'll go over the correct answer in just a moment. Okay, Jeff, it looks like everyone's getting the right answer on this one. Can you go over it for us?
Sure. So the correct answer here is relaxation times. MRI doesn't give us any direct information on electron density. We'll go into that later. It is affected by water concentration, but there's very little difference in water concentration between the different tissues compared to the differences in relaxation times. And the quantum levels is a whole different thing that was just put there as a distractor. So you guys are doing good. The next thing I want to talk about briefly are MR artifacts, and particularly those that most influence studies done for radiation therapy purposes. And the three that are highlighted here in red are the three I'm going to talk about: geometric distortion, magnetic susceptibility differences, and motional ghosting. Some of the others that can occur and may, in some instances, be important to take into account and remediate or calibrate are A-listing or wraparound, signal intensity non-uniformities, chemical shift artifact, and truncation artifact. So probably the most important, at least it's the first one you have to deal with usually, is MRI distortion. And these can be system-induced distortions or patient-induced distortions. The system-induced distortions come from the fact that magnetic field lines are not linear. They're always inherently curved. And so you may get a quite linear, both your gradients and your main magnetic fields at the center of the magnet, but as you go away from the center of the magnet, they're going to start to curve, but they're going to curve in ways that are known. So the center of the magnet we usually call the isocenter, and that's where the prescribed imaging is done. And usually if you're doing small fields of view, you can position the body part you're interested in and image in the middle of the magnet, and you get really good geometric reproducibility. If you want to go out a little bit further, say 10, 20 centimeters away from isocenter, most of the vendors provide some kind of three-dimensional distortion correction algorithm because, again, these distortions are known. It's known what they are, and they can calculate based on the geometric properties of the magnet coils and the gradient coils. However, it's limited by the field of view, and what's been adopted in a lot of radiation therapy centers as a workaround for this that at least helps in the head-foot direction is what's called a step and shoot approach. Most MRI scans are done where you just sit the patient at a certain spot and you scan at that spot. But with step and shoot, you actually increment the table as you would with a CT scanner to ensure that the part of the body you're interested in imaging is as close to isocenter as possible. I mentioned the patients produce artifacts themselves. This is an example of a susceptibility artifact that shows up in your gradient echo or gradient refocused echo and is due to phase errors that occur at regions where there's a large gradient produced by differences in magnetic susceptibility of the tissues. So here you can see the black arrows pointing to the temporal region of the brain, and that's because the temporal sinus is there. And so you have a large distortion caused by the difference in susceptibility between the skull and the air in the temporal sinus. And this adds an additional gradient which shifts the signal away from where it's supposed to be. And it gets worse the longer the TE is because the phase errors have a longer time to build up. And so these are just artifacts you have to be aware of. It's not so bad on a spin echo. Well, it's probably minimal on a fast spin echo. It's not so bad on a spin echo. Then it gets worse on a gradient echo. And if you go to something that's really fast, like an echo planar image, it gets really bad. But it's not just natural things in the patient that can cause distortions. This is a patient that has braces. And so they're in their teeth, and you see the whole bottom part of the skull has been obliterated. And even in the images that are taken in the upper part of the brain here, you can still see some artifacts due to the metal in the mouth. And so one of the things we're going to have to deal with is ferromagnetic objects in the patients, because many of our patients have some kind of prosthetics. Another issue is ghosting that's produced by motion in the patient, particularly breathing in this image of the abdomen. These types of artifacts appear in the phase encoding direction. So in this case, the phase encoding direction is anterior posterior. These occur because the data is acquired at different points in time as the patient is moving at different places, and so that distorts the, remember that we're the phase of the signal, and we're counting on the phase of the signal to be consistent so we can encode position in the phase encoding direction. So we need to come up with ways to manage that. So which of the following MRI artifacts becomes worse with increasing B0 field strength that could distort MRI images used for treatment planning? Motion artifacts, wraparound or aliasing artifacts, susceptibility artifacts, or RF coil artifacts?
Okay, great. Let's give everyone just a moment to answer this poll question, and then we'll review the answer in a moment. Okay, Jeff, it looks like almost everyone is answering C.
You guys are keeping up pretty good. Okay. And that's correct, susceptibility artifacts. Okay, so that's the background stuff. Let's talk about how MR images are used to help with radiation therapy treatment planning. In radiation therapy, both standard MR imaging techniques I've been talking about and more advanced techniques are used, but we're going to concentrate on the standard ones. They're used, again, because the high soft tissue contrast allows better targeting of organs at risk and target organs as well. However, there are major limitations. Some relate to those artifacts I talked about that have to be dealt with before we can do it. And in the long run, and what's going on right now is people are developing novel approaches that are protocols specifically dedicated for radiation therapy to acquire MRI images that are compatible with those. So in general, in most cases, when we're doing MRI for radiation therapy, there's a few things that we need that we don't need in a standard diagnostic study. One is we need typically large fields of view to provide adequate visualization of target as well as the surrounding radiosensitive organs at risk. And then typically we'll want to do 3D isotropic imaging, so we'll use gradient echo or fast spin echo pulse sequences, and we'll want it to be very high resolution. So outside of the brain, maybe 1 by 1 by 3 millimeters. Inside the brain would be even better if you get down to 1 by 1 by 1.5 or 1 by 1 by 1. So that's a pretty high resolution, and one of the reasons that 3T systems are becoming preferred, because you can easily achieve those resolution goals. You have the signal and noise to do it in a short scan time on a 3T system. And when you're doing isotropic imaging, that means you can display the data in any orientation you want. So here's an image of the cervical region and the lower jaw. And you can see these are sagittal display, and this is a axial display. But this is the same data, just reformatted and displayed different directions. And so that's what's so desirable about getting isotropic data, is that it doesn't matter which projection you display it in, you get high resolution all the way, which you don't always get on CT scanners because of minimum slice thickness requirements. In order for this to work, though, as a treatment planning tool, you need to have good spatial fidelity in your images. And I already talked about geometric distortions and how they arrive from both patient-specific sources and system sources, and how we can kind of manage the ones from system sources with a priori knowledge of the way the system is engineered. But you still need to do a calibration. Different pulse sequences are influenced by distortion differently. And so people have been developing distortion calibration phantoms specifically for use in radiation therapy applications of MRI. Here is on the left is a large body type phantom. On the right is sort of an anthropomorphic brain phantom. Both are compatible with MRI. Both can also be used in a CT scanner for calibration. One of the things I've seen and some people do is build phantoms on their own that are basically plastic boxes filled with some kind of matrix that localizes it. You should not use plastic boxes. Sharp edges will in and of themselves cause susceptibility artifacts. And so this long cylinder here on the left is okay. It has sharp edges here, and the ends will be sharp drop-offs, but you can get a lot of information from the very middle, though the last couple slices may not give you good information. This is probably preferred, just having it as close as you can to the way the actual head of a patient would be. And this particular phantom even has holes for where the ear canal would be to simulate the susceptibility artifacts you'd get in a real skull. This picture shows how the MRI distortion can vary by pulse sequences. On the left, we have our turbo spin echo, a fast spin echo sequence. There's a single shot and a 3D and a regular turbo spin echo. These are both done on a Siemens 1.5T scanner. On the right, you see the gradient echoes. You can see the susceptibility, the distortion caused in the gradient echo is generally greater than in the spin echo, the fast spin echo, at least until you get out to the periphery. And the reason for that is the spin echo, the fast spin echo has all those 180-degree refocusing pulses. And they refocus a lot of the problems due to just susceptibility that contribute to distortion. In the same article, if you want to look it up, they also looked at a Philips system, and its distortion profile is very different. So you can't use a correction from one scanner on another. You have to do it for that scanner and that pulse sequence. This shows a corrected, uncorrected, and corrected image and the amount of difference you have between a corrected and uncorrected image. And this is presumably done pretty close to the center of the magnet. So even there's going to be a tiny little bit of correction you can see. So as you know, CT is the primary image modality used for radiation therapy treatment planning these days. The risk of a single CT scan isn't small in terms of the radiation risk, but these days a lot of patients are subjected to adaptive replanning. That means rescanning, and if they have prolonged survival, they may be coming back in 2 or 3 years or 5 years or 7 years, and their lifetime exposure to CT can be sometimes quite significant. MRI is being more and more used as a secondary data set that's fused with CT images to transfer target and organ at risk contours to this superimposed on the CT image. And this fusion process itself introduces uncertainties and potential errors in treatment planning process. And that depends on the type of fusion software you're using, and that needs to be evaluated and understood as well. That's beyond the scope, but this just kind of shows an example of, so here's an axial MRI. Again, you're acquiring a 3D data set, so you can also look at it in a coronal view here, and you can contour the edges of the lesion very well with the MRI, and then transfer those contours over to the CT scanner and get a volume on top of your CT data, and then do your treatment planning from the CT data as you would normally. But it would be preferable, rather than having to transfer the data and do a CT scan and an MRI scan, just to use the data from the MRI itself. And aside from distortion, one of the biggest problems with MRI is calculating the attenuation coefficients of the tissues based on the MRI data. So to do this, you need to have, as we talked about, accurate geometry, but you also need to come up with a way to calculate electron densities based on your MRI data. And you can do this by looking at water and fat images of MRI, quantitate how much water and how much fat. And then there's a method that I'm not going to go into detail on called ultra short TE that can be used for imaging cortical bone with MRI. And this is some data that just shows you how this MR image intensity value in one particular scan, well, actually, yeah, it looks like an abdominal scan. And this is the CT Hounsfield units. And the only place there seemed to be any strong correlation here is in the cortical bone, where you have low signal in MRI and high signal in CT, and the rest of it is kind of a mishmash. So we'd like to change the workflow and make MRI the primary imaging agent. And in order to do that, we have to provide reliable surrogates for electron density information and dose distribution calculations. And so work is being done to prove this. This is a general area called simulated CT. And the big problem is, if you look at it, MR signals can't directly be related to tissue density, electron density, or other tissue parameters. The contrast, again, is mainly from T1 and T2. Therefore, it's going to be hard to get MRI grayscale values to directly translate to relative electron density. It requires special methods. And so, as I mentioned, one of the methods is this multi-parametric approach, where we can combine data from T1 weighted images, T2 weighted images, and other sequence, including fat images and water images, and these ultra short TE images to give us really good measurement of cortical bone. And this seems to be the approach people are looking at it. A similar type of approach is being used to get attenuation information from MRI data in PET MRI systems, so that you can use the MRI data for attenuation corrections in PET images as well. So here's an example. Here's your CT image on the top left, your T1 weighted image, your T2 weighted image, and then there's multiple types of ultra short TEs you do in order to get the cortical bone. You usually do at least two. So here's UT1 and UT2. And then you can acquire through what's called a Dixon method, Dixon imaging, acquire a fat and water image based on the chemical shift of fat and water, causing their spins to precess at different phases. And so here's a fat image. This is all fat alone. This is all water, just water, no fat. And you can even go and use MR angiography to discern where the vascular structures are if you might need those for a treatment plan. So this is what we mean by multiparametric MRI. We're really taking advantage of the different types of contrast that are available in MRI to give us information that we can relate and calibrate into some kind of treatment plan. Which ones you use depends on what kind of study you're doing. So this is just some examples listed in a table from one investigator where you can look at the different sites here, so different parts of the body they're looking at: brain, breast, liver, spine, cervix, head and neck. And in the head, you can do most about anything. In the head here, they use axial sagittal T1s. Again, that can be one scan with an isotropic scan. They apply contrast agent and do as well. And that allows you to measure breakdown of the blood-brain barrier and better identification of the tumor margins. Axial fat suppressed T1 to look at the scan without the fat. Axial T2 inversion recovery to, again, it's get rid of the fat. And then you can calculate the post-contrast minus the pre-contrast brain image. And then if you're so inclined, you can also do diffusion imaging. As I mentioned, that's becoming a big thing for following up effectiveness of therapy. And if you do that, here's the CT image and here's the MRI image, a T1 weighted MRI image. But here is a synthetic CT compiled completely from the MRI data set. And you can see it bears a lot of resemblance to the actual CT. And so people are investigating how good this type of approach is for treatment planning and tweaking different things. And there's quite a bit of research activity going on this. And I suspect it's far enough along where I suspect to see some commercial products coming out very soon. The other big problem is managing motion in MRI. As I showed you, the motion ghosting artifact is very bad, and it's been so bad for so long that people that do MRI physics and engineering have come up with various ways to suppress motion-related artifacts. The big ones are, of course, motion due to respiration and motion due to cardiac motion during the heart beating. But you can also get motion from blood flow, cerebral spinal fluid flow, peristalsis, and the abdomen. If you don't do something about the motion problems, they can lead to a lot of uncertainty about the exact location of your targets and your organs at risk. So the simplest way is to do breath hold acquisitions, and their MRI is getting fast enough where there are plenty of applications where you can get away doing breath hold. But some people can't hold their breath very long, some don't do it very well, and so you need to come up with other strategies. One of the ones commonly used for imaging the abdomen in the radiology department is respiratory gating. This particular approach uses what's called a navigator echo, where data is acquired from a small piece of tissue very quickly, and it's placed typically right at centered on the border of the liver and the lung. So this is the diaphragm here, and you monitor the diaphragm movement, and you go ahead and acquire your data, but you set a certain range in here that you only allow so much motion, and you reject those acquisitions that occur when there's too much motion. And using this is the gated acquisition. You see it has much less motion artifact than the normally acquired data set does. Now, 4D imaging has been a hot topic in radiation therapy for a while now. And MRI can acquire images in arbitrary planes just by changing the gradient directions. And if you acquire two non-coplanar image views, then you can combine critical motion characterization. So if you go back to this one, not only have one on the diaphragm, but also one on the chest wall, then you got it covered. And using parallel image acquisition with large array coils allows us to accelerate the process using 16-fold acceleration for a 32-channel 3 Tesla system, and even faster methods are being developed. In addition to motion tracking techniques, you can use some retrospective acquisition methods. These use what's called a radial case space acquisition method. They go under names like TRIX and Propeller that can be used to quantify the motion and reduce motion artifacts. And also, you'd like to quantify the amount of motion present during respiration that's of a time span similar to what's experienced during normal radiation therapy. So you want to get kind of an average amount of motion too to help target treatment. And you can do that with MRI, and people have developed systems that can do it. This isn't commercially available yet, but in time it will be. And once you have this, it'll compensate for target motion during radiation treatment, which will reduce exposure to your organs at risk, and can be used for 4D treatment planning and 4D radiation delivery, and particularly with the advent of these MRI Linac systems, this is becoming a very hot area of development. Now, 4D CT respiratory motion has been around for quite a long time, but again, CT lacks soft tissue and tumor tissue contrast and gives ionizing radiation. And that limits acquisition time and thereby the degree to which variable breathing motion could be sampled and characterized, and sometimes required the use of iodinated contrast agents as well. And so this is a fairly recent study that came out of the group at Medical College of Wisconsin, where they're using these types of undersampling things I was talking about, that do sparse sampling and really increase imaging speed. It's called compressed sensing. So this is a CT, this is a 4T MRI, regular one, and this is a 4T MRI with compressed sensing. And you see there's not very much difference in image quality, but there's a little less motion artifact. So what I want to do for the remainder of this talk is just talk about specific types of specific areas of the body you might want to be using MRI for your treatment plans to give you a sense of the different types of issues you have to address for each type of body part you're imaging. The brain is probably the part of the body that's the easiest to image with MRI. There's a huge amount of neurological research, and for a long time, MRI was considered primarily a neuroradiological tool. That's because the brain is relatively small compared to other body parts, fairly spherical in shape, and easy to position in the isocenter of the magnet. In the brain, MRI provides really good visualization of tumors and good contrast between tumor and normal tissue, way better than CT. And you can do really high precision intracranial radiotherapy using MRI studies. However, you can't do it the way they scan the brain in the radiology department. In regular MRI, you have what is called the head coil that you stick the head in and you do your brain scans with. But those coils are designed to be placed as close as possible to the patient. So they even have a little indentation for the nose. But that doesn't work for radiation therapy studies because they don't leave room for immobilization devices. Also, you want to just image the patient and the MR scanner in the same position they are in the treatment position. So that usually requires the use of an index flat top table. And often you want to include an immobilization device. So here's a example showing how this is dealt with. So here we have not a head coil, but two flexible surface coils that are put on top of the immobilization device here, and there's a flat table here. In addition, as I mentioned before, you're going to want to have a little larger field of view. You're going to also want to use a higher receiver bandwidth that will minimize chemical shift artifact and susceptibility artifacts. You want increased image intensity uniformity for registration. You want to keep your geometric distortion correction such that your distortions are less than 2 millimeters. And if you're imaging and there's motion, you want to have your breast hold tailored to match gating windows using gated radiotherapy delivery. And because of it's relatively easy to do so, and MRI is being used more commonly in treating brain tumors for fractionated radiotherapy, fractionated stereotactic radiotherapy, stereotactic radiosurgery, and functional radiosurgery. So treatment target for a patient having high-grade glioma can be determined from usually your T1 weighted 3D spoil gradient image, high contrast, contrast enhanced, so you're giving gadolinium contrast agent. That defines the gross visible disease that's indicated by the contrast agent leaking into the lesion due to compromised blood-brain barrier. Also, a standard 2D MR image using a fluid attenuation inversion recovery that gets rid of the signal from the CSF based on its T1 that helps to define the clinical target volume extent of edema. And so here's an example of a treatment plan. On the left is one where you acquire the MRI data and fuse it with the CT data. And on the right is one where it's just done with the MRI data alone. And so if you're careful about your geometric distortion and all, you can do quite a good job with just the MR data, particularly with brain imaging. Another example is doing treatment plans for breast tumors. This would be quite beneficial because CT gives you very little definition of soft tissue in the breast. And usually that's done by palpating the breast and then putting some kind of radio-opaque marker on it. MRI not only detects breast glandular tissue better than CT, but it allows using gadolinium contrast agents to differentiate between malignant and benign tumors with a fairly high degree of specificity. However, people who have done this, used MRI for treatment plans, have yet to demonstrate that whether this improved delineation of the tumors in the breast actually affect clinical outcomes. But anyway, so breast abnormalities are visible in MRI using both non-contrast and contrast-enhanced techniques, and it has a greater sensitivity over mammography for the assessment of the extent of breast cancer. The thing is that standard postoperative tangential radiotherapy, which is used following wide local excisions for early breast cancer, is used to treat the breast volume. And if you look at your regular diagnostic image of the breast, it looks kind of like this. Now, it looks like the breast is upside down, and the reason I presented it this way, because diagnostic breast MR studies are actually done with the patient prone in the magnet, and the breasts hang down into specialized RF coils that circle each of the breast. But they do typically do T1 weighted contrast enhanced 3D isotropic images with a 30 to 40 centimeter field of view. So that part is good. But this is nowhere near the same positioning that somebody would have with their undergoing breast radiotherapy. So instead of having the MRI done with the patient lying prone and the breast suspended in an RF coil, like to position the patient as they would be in a radiation therapy setting. However, a big problem with this is that the patient is laying supine and the breast will kind of be more to the side away from the isocenter, and that's going to cause issues with geometric accuracy. So here's some examples of using MRI to do treatment planning. MRI is particularly good at compared to CT. Here's the CT, and so what they've done is they've drawn 4 different contours here to delineate the extent of the breast tissue with 4 different observers. And you can see compared to the CT, there's quite a bit more agreement as to what those margins are for the MRI study here. And of course, again, with the MRI study, you can reformat it and get very good resolution in a sagittal mode here. And there's greater differences between the 4 observers and what the superior extent of the breast is. Last one we'll look at is prostate treatment plans. MRI is recognized as superior imaging modality in defining the prostate volume accurately. You can do all kinds of advanced studies on the prostate as well to look at its metabolism, perfusion, and various other things. Prostate scans can be acquired using the treatment position on a flat top table and a posterior RF coil placed underneath it without too much loss of quality. Many diagnostic prostate studies, they use an intrarectal coil. It puts the RF receiver right up on the posterior portion of the prostate gland so they can get very good solenoids with that coil and therefore get high imaging resolution. And you really don't want to do that when you're doing radiation therapy planning because you're not going to have the coil in the rectum while you're doing the treatment. So this shows an example of, this is again, a flexible matrix coil here. This is on a phantom, and this is what a person would look like on a regular MRI patient couch, which is concave, but you put the flat couch top on here, and these are differences in the images. You can see this, it is somewhat different. Of course, here's the prostate gland. You can see here it looks a little more elliptical, and here it looks a little more round, which is what it's going to be like when it's in the accelerator getting treated. So we expect to see hardware modifications, and I wouldn't be surprised if the companies that make MRI scanners come out with essentially what are going to be MRI simulators that have coils and such that are specifically designed for radiation therapy applications. One of the exciting technologies that is coming out now is matrix coils with a high number of elements that are very thin and very flexible. They're almost like electric blankets in terms of how flexible they are. And we're seeing some of these being adopted. They're being made by third-party RF coil manufacturers, but they're being made compatible with some of the newer MRI scanners. And typically the ones that are 32 channels, 64 channels or more. One place where MRI has been found to be very good for prostate treatment plans is in cases of bilateral hip replacement, because the beam hardening artifacts on the CT are difficult to overcome. And however, in MRI, there are ways to get around susceptibility artifacts and make them confined only to within the prosthesis. This is done with what we call metal reduction techniques. Some of the techniques are limited to two-dimensional acquisition, so they aren't completely useful for 3D acquisition methods, but there's no reason these algorithms can't be extended. I just want to show you an example. So this is a a femur. It's the head of the femur. It has a prosthetic in it that secures it to the pelvis. And here's the type of susceptibility artifacts you get normally. But when you apply artifacts reduction, you can see that the long metal piece, I don't know the name of it, that's sticking down into the head of the femur, the artifacts are kept well inside of it. And there's a little bit of artifact here, maybe a little bit here, but it's substantially reduced. And you should be able to do much improved treatment planning around that metal prosthetic using this artifact reduction. So last question, which of the following accommodations are often required to adapt MRI to radiation therapy applications? Use of a dedicated RF coil shaped to the body part for each treatment plan, flat top table added to the MRI couch, smaller fields of view than the normal MRI diagnostic protocols, are electron density calculated from water-only MR image.
Okay, great. Thank you, Jeff. It looks like everyone is on this question, and everyone has already responded, it looks like. Most people have answered B.
That would be correct. Most of the dedicated RF coils are not designed for radiation therapy now, so you have to end up using these small matrix coils. Smaller fields of view are actually usually use larger fields of view than normal for radiation therapy applications. And if you're going to try to do a CT simulation, you're going to need more than a water-only MR image. You're going to need a water-only, a fat-only, and probably some kind of bone measurement as well. So I wanted to kind of finish up here with kind of going over, and I try to lay out the kind of knowledge you're going to need to do MRI physics in the radiation therapy environment. It depends on what kind of task you're undertaking. For distortion correction, you're going to need a basic understanding of NMR physics, good understanding of image formation and artifacts, some idea of MR technology and quality control, and of course, and this is something we could do a whole lecture on, is MRI safety and site management in radiation therapy, because it's going to be much more complex than it is in a diagnostic radiation therapy, in a diagnostic MR suite type setting. You got the synthetic CT processes. You're going to need to understand advanced MRI methods, contrast agents, and probably cardiac MRI as well, just so you can handle doing things like planning for lung cancer therapies. You get a combined linear accelerator with an MRI system. You're going to need all this and a lot more. 4D MRI, again, all this plus more. And if you want to get into treatment responses, you're going to have to get into very advanced MRI methods and understand some biology of cancer as well. So you'll be able to relate what you're learning from the MRI studies to cancer biology and how you want to treat it. And in this, there's also, you're going to find greater applications of PET MRIs in this treatment response thing too, because you can get a lot of information combining PET and MRI. So to summarize, we talked about how MRI can provide exceptional image data for multiple tasks that you undertake in radiation therapy. We just focus mainly on treatment planning today. The use of MRI in radiation therapy requires a high degree of confidence understanding of the sophisticated MRI methods and procedure. Increasing integration of MRI into clinical radiation therapy gives us the opportunity to increase therapeutic accuracy and safety, improve treatment outcomes, and increase survival rates with fewer radiation-induced side effects. But these are early days, and we're still trying to figure out the best approaches to do that for different types of treatments on different body parts with different types of tumors. There's still a lot left to be learned. And so I thank you for your attention, and again, thanks for tuning in and listening to this lecture.
Thanks so much for presenting this webinar, Jeff. We have a lot of questions in our chat room, Q&A questions, so I was wondering if we could get to some of those before we let you go.
Okay, so let's see. David said, people get hurt by MRI scanners. Do you think it would be an issue? Yes, absolutely. Like I said, we can do a whole talk on just safety issues. Yeah, I know Steve Ryder. Yeah. If you have fat, water, and cortical bone with relatively known densities, what types of dosimetric difference, if you were to plan? As I showed, you get pretty close. If you know fat, water, and cortical bone, then you go a long ways to being able to simulate a CT scan. But the cortical bone scans are not common things, and even the processing for the fat studies, people are coming up with better ways to do it. Absolutely, you should use different phantoms for different types of distortion measurements you're doing for different studies in different parts of the body. If you only have one on, you need to get that big field of view one, though. Like I said, the anthropomorphic head phantom also tries to simulate some of the susceptibility differences between tissues. Well, will we be sharing the slides with participants? I don't know.
Oh, we will be sharing the slides. They'll be available on the WePass library. We'll also have this recorded webinar available on YouTube. Wanted to make sure everybody knows that if you are joined the webinar late or weren't able to catch most of it. So we still have a couple more questions down here. Jeff, one from Natasha.
Yes.
Did the patient with braces have any other issues because of the braces and magnets, or was it limited to artifact?
We image patients with braces quite a bit. Most braces are made of stainless steel, which are not ferromagnetic. You have to be careful about heating, though. Radio frequency pulses can set up eddy currents in metal objects that can cause heating. As long as you're using relatively low power, RF power sequences, we call those low SAR for low specific absorption rate, you can avoid that type of heating, where it might be noticeable but not uncomfortable.
All right.
Geometric distortions are not that stable. You should probably do these. I don't know if you need to do this every day, but you probably need to characterize them, I would guess, on a weekly basis. But there's no standards for that, so I don't really know. That's just what I'd feel comfortable with, is doing geometric distortion characterizations on a weekly basis. I don't think the sparse sampling methods, depends on which sparse sampling method you're using. Some of them could cause their own distortions, and so that's something that's going to have to be worked out as people develop this technology. Can I give an example of diffusion-weighted MRI? Yes. I mean, diffusion-weighted MRI is used to characterize cellularity of the tumors. So that gives you a good idea of tumor response to not only radiation therapy, but other types of treatments like chemotherapy. And there's a fairly large literature of people who have been using this for about 10 years in clinical trials. And it looks quite promising.
Okay, great. Thank you so much for answering all those questions, Jeff, and thank you again for presenting this webinar. And thank you all for joining us for this free event hosted by WePass. If you'd like to review this webinar, it will be available for a limited time on the WePass YouTube channel. And be sure to register for the next live WePass webinar on the effect of CT parameter adjustment and patient size on radiation dose and image quality, presented by Dr. Donovan Boucalier on Wednesday, April 11th at 12 p.m. Eastern Daylight Time. This and other recorded webinars are always available to WePass subscribers 24 hours a day, 7 days a week, so be sure to register through wepass.com to become a subscriber. And for up-to-date information about upcoming webinars, be sure to follow WePass on Facebook, Twitter, and YouTube. Thanks again.